All right, we are going to go to page 1. Why we started this book on this topic, I don't know, but page 1 is medical errors. This is a really, really important topic, and it's gotten a lot of press lately, a huge amount of press lately. And it's something that I think as a profession we're a little bit uncomfortable with, maybe even a lot uncomfortable with. I didn't write this chapter, Greg Henry did. I kind of approached this a little differently than he did, so I'm going to kind of wing it a little bit on this. The abstracts to support what we're going to talk about are in here, and a lot of these abstracts are editorial pieces, position papers, very few true studies in here. There are some, but most of the stuff is just, here's what we think kind of papers in here. So let's start off with what is a medical error. And there actually is an abstract in here that I think is interesting, which is abstract number 2. Abstract number 2 is a paper that did focus groups. And what they did is took a group of docs and stuck them in a room and did a bunch of talking to them. A bunch of patients, stuck them in a room in focus groups, talked to them, and then a couple groups that had combined patients and docs together. And before they did these focus groups, they defined medical error to each person so that they, as a group, understood what medical errors consisted of. And then they basically went into these sessions and had discussions about medical errors. What they found out is, despite being told what a medical error actually is, patients consider different things medical errors than doctors do. And patients lump in things like, I waited too long, in what they consider a medical error, something that should be disclosed. Things like, I didn't like my doctor, as a medical error, so part of the beginning of the whole concept of medical errors is, do we think what are medical errors are the same thing as the sort of consumers of our product think are medical errors? And the answer to that is no. We think very differently on what is actually a medical error. So we have a different approach to this than patients do. And that's important to at least know. God, this is driving me crazy. Hang on a sec. To at least know, because if we're going to try to address this, if we're going to ultimately get down to the idea of apologizing for medical errors, then we should at least have some idea of what our consumers have in mind. Now, that doesn't mean you have to bow to that, to say, oh my goodness, we made a big mistake making you wait, 10 hours instead of 6, or 12 minutes instead of 6. But it just is important to understand that the receivers of our product have a little bit different view of this than we do. So that's kind of the kickoff to this. The next sort of step is, should we disclose errors? What do you think patients think? Of course. What do they want to have disclosed to them? Everything. Everything, including no harm, no foul medical errors. You've got 2 pills of ibuprofen when I ordered 1. They want everything disclosed to them. That's the consumer's viewpoint. Not only do they define things a little differently than we might, they want everything disclosed. What do you think doctors think? The papers are in here. What do we think should be disclosed? Only harm. And a lot of physicians feel so they got 2 ibuprofen instead of 1, it's not a harmful thing here. I shouldn't have to disclose that. Docs have a higher bar we set for what we think needs to be disclosed. So this is part of the playing field of the concept of medical error and disclosure is patients lump things into errors that we may not consider errors. Patients want everything told to them that is a mistake, even if it doesn't cause any harm. We think of it differently. We think that our definition of medical error is much tighter, and what we think needs to be disclosed is much narrower for what we approach to this. Now, what is the downside of disclosure? Why do we even hesitate? Why don't we come up and say, dude, sorry, lost the wire into you. Really sorry about that. Why don't we do that? Malpractice is one, and we're going to come back to that. Okay, because I'm going to be, hopefully, at the end of this 20 minutes or so, be able to convince you that although disclosure may increase your risk of being sued, it will decrease the amount of money that gets awarded, if any. So malpractice is one of the reasons we don't disclose. What's another? Shame. That is huge. There's a paper in here called The Second Victim. In medical errors, it's not just the person who had the error occur to them that is the victim. Doctors are the second victim. And part of that is shame. We expect perfection of ourselves. We expect perfection of our peers. And to go to someone and say, God, I cannot believe I did what I just did. I've been there. I did lose a wire into a patient. When I was an intern, I was putting in a fem line, and in went the wire. Forgot to grab it on the other end, shoved in the dilator and the cordis sheath itself, and in went the wire. To this day, I am mortified by that. To this day, this is 20, God knows how many years later, I remember that as vividly as the day it happened. Shame, what it does to you when you commit an error, especially I can't go buy this person another femoral vein. It's not like a television set where, oh, whoops, I crossed the wires wrong and blew it out. I can go buy another TV. I can't fix it if I do. And if you do something that is a fatal mistake, it is devastating to you. And the reality is we all make mistakes. There's no question. You will, if you haven't, you will, and we all have. We all know we have. We had beers, we could all share stories. But so disclosure, there's a bunch of overlay. There's the I don't want to get sued part, but there's also the, oh my goodness, I'm so ashamed of myself. I am mortified. I'm so guilty that this happened. That is a big part of why we don't disclose. Any other reasons you don't disclose?
It takes time.
It does take time. And it's very important how it's done. So it's not just his time to go in and say, it'd be nice for you to say, hey, dude, screwed up, sorry, and leave. You can't do that. How you do your disclosure and how you make an apology is really critical on how you do this. You have to do it very carefully. So the milieu we're practicing in here, as far as what we do, what is considered an error varies depending on us versus the receiver. What we are supposed to disclose, expectations-wise, varies from the patient's point of view from ours. We have a lot of trouble admitting that we've made a mistake for a whole lot of reasons. It's a very complicated thing, and we are in a specialty, a medicine itself, and emergency medicine in particular. I can't think of a better setup to cause mistakes. Can you? Think about your emergency department at any moment in time. You are interrupted on average once every 3 minutes when you're doing an emergency shift. Once every 3 minutes. That's 20 times an hour where your thought process gets interrupted. You've got people everywhere. You have noise everywhere. You have systems with which you are interacting. It is amazing to me. We don't knock off more people than we do. Okay, I mean, it is remarkable. And it's only to the resilience of the human body. People are amazingly resilient overall. That we don't knock off more people than we do now. So, overall, the milieu is a setup. The problem is that it's not just us that are the issue. Okay, we are an interface between a lot of other things. So a bunch of these papers that I'm not going to delve into, you can read, but they're really worth reading, particularly abstract number 1, which looks at the concept of medical error is not, it is an inherent thing that will happen. There is not a perfect setup. Error will happen. What we need to do is try to minimize it by looking not just at, oh, you ignorant slut, how could you do that terrible thing, but more as a systems issue. How many of you have mandatory disclosure where you work? I have mandatory disclosure. Okay, it is a LA countywide policy. It is mandatory disclosure of any medical error that occurs must be disclosed to the patient and must be reported in this thing called a patient safety net, which is we have an online, the minute anything occurs, even if there's no untoward effect, it must be reported in a safety net system, which is actually cool because what it addresses is the system part of mistakes. Sometimes it's me. I need to go back and take more CME. I should have known X. More often than not, it's I knew the right thing to order. The nurse actually put the order into the pharmacy correctly. What got sent down was wrong, and that's why it got given wrong. So it's a system problem. So things like these safety nets, where I type in what the situation, patient arrested out in the waiting room because we have a 24-hour wait and our nurses hadn't gotten to that person yet to get triaged. Okay, that is a system. That's not my mistake. That's a system issue. So that's a big part of this disclosure deal, is to understand that it is rarely a single thing that causes the problem. It's often a multifactorial system issue that does it. There's a bunch of papers in here then that look at, can we address mistakes and make them better? We absolutely can. But the key is to understand that to not talk about them or to not admit that they occur is to undermine the process from the very beginning. The bottom line is to know they occur, we all know they occur, and to address them up front. And it is really counter to what most of us are comfortable doing. And it sort of has to change, it has to be sort of a systems change or a milieu change to do that. What if you have somebody come into you, let's see, how does this work? I've got a case of this recently. A patient who was sent to us, we have a lot of these, who was seen in the community for a lung infection. For pneumonia, that was given the absolutely wrong antibiotic, like an antibiotic that does not work on pneumonia at all, and came in really, really sick. Had been seen by the PMD twice, had been given a non-pulmonary drug, and came in to us really, really sick. That's a mistake on the other practitioner's part. What do you all do in that situation? We have this happen in the ER a lot, right? They're not getting better for something, or they're feeling worse about something, and they come to see us. They've been seen already by somebody for all. What do you do in that situation? What do y'all do? What do you do?
Well, in our system, I work at Kaiser. If it's an egregious error, I call QA for
Okay.
physician's department. If it's an oversight kind of thing, I'll usually just leave a message with the physician themselves.
So you make a direct contact to the physician, or if it's an internal system egregious thing, you go through your own system. And I think that hits some of the points that are appropriate. What do you all do? How many? Let's be honest, okay? We'll close the door. This isn't. They only have the camera on me. What do you really do? Nothing. And we don't. You are ethically. If you look at medical ethics, which is a fascinating, even though it's like ethics. If you want to kill a course ever, just mention the word ethics, and everybody goes instantly to sleep. Really, seriously. But medical ethics says if you are bound to acknowledge and address an error, even if it's by a colleague. Ethically, you are bound to this. We don't do it because a lot of us say, well, there, but for the grace of God, or I don't know what happened. I think your approach is good in that. Before you say to the patient, geez, what a stupid doctor you went to see. What were they thinking? How could they possibly have done that? It's very important to understand why whatever happened happened. So first and foremost, don't go blasting ahead with, oh, I see that the residents do this a lot. At a county hospital, we get lots of transfers in, and lots of people have been seen in the community and are uninsured. They're seen by some nice doc who's willing to take care of somebody with no health care coverage, who finally says, you're too sick, go see them. And the residents will say, oh my, geez, these doctors in the community are so stupid. How could, wait a second, you don't know what happened. So before you go blasting ahead with somebody who was an idiot, make sure you know the situation. But then, if it truly is an issue, it needs to get addressed. And most of us don't do that. And I don't know how to fix that. In a Kaiser system, because you're internally, you're all in the same system, it's something that can be addressed through that system. It's harder out in the private sector. I don't know, yeah.
I had a lady, a guy who was in his mid-40s who came in basically dead after being sent home by two of my partners. Had an acute MI when he came, had an acute MI. And he had two sets of cardiac markers that were drawn, and the second set was not positive but did go up. And the family, with the 5 kids and the mom, were asking me why we sent the patient home. Mm-hmm. And my answer to them was, I don't know, I wasn't there.
Exactly.
And I don't know if that's the appropriate answer or...
Well, I think the thing that is not appropriate to do is to say, oh, geez, they really screwed up. Good thing you got me now. That's not the appropriate approach. And part of it is you don't know what happened. So, but what you can say is, I can look into this. And let me look into this, because clearly something bad happened. Sometimes bad things do happen. That's just part of illness. But let me look into this. And then if you do find there's an error made, we'll talk about it. But then disclosure is really important. It's crucially important, and it's part of the way things are these days, and it should be. Should have been for a long time. So that's an important sort of approach thing to think about. Now, say you find, you go away from that bedside, you do your investigation, and you find that your two partners really made a mistake. How do you address that then? How many of you are the person, or have done, the apology? Okay, tell me what you do. Were you trained, first of all?
No.
Okay, so tell me what you do.
I was trained by my first patient.
Mm-hmm.
He said, respond immediately, say there'll be an investigation, find out what happened. And most of the patients that I dealt with wanted to know that something in the system was going to change so this didn't happen to somebody else.
Exactly. This is really, really important. The one thing you don't want to do, and especially since we're all perfectionists and we all feel terrible when something goes wrong, you do not want to supplicate yourself and just basically beat your brow in front of the patient. I am so sorry. I completely screwed up and that your loved one died and I'm just feeling terrible and I'm terribly sorry for that. Wrong. Okay, you don't do that. What you do is you acknowledge that an error was made. Okay, I am terribly sorry that the drug dose was incorrect. You don't say, I'm sorry that this stupid nurse pulled the wrong drug out of the drawer and pulled up the wrong dose. You address the event and say, I'm sorry for the event, not I am sorry that I made a mistake or something. You don't know yet exactly where the mistake was made necessarily. So I am sorry for the event. That's the first thing you do. You offer redress. We will investigate this to see exactly what happened. You offer some sort of recompense in that. We will look at your hospital bill and determine whether, what is going on here as far as what bills are, charges, et cetera. Will there be some sort of recompense? And we will make sure that we address this such that it doesn't happen again, or we minimize the chance of it happening again. And there are classes to take on this, and there are monographs. The ashram, it's at the very end of your chapter there. There are actually some really good monographs that take you stepwise through. And if you're at the moment of an error occurring, and you know it's happened and you've acknowledged it, it's probably better to say, there's been an event, we are going to investigate this, and stop there before going anything, because often hospitals have their own person to do this or their own teams to do this. So acknowledge it then or report it to them, but let it it needs to happen. There's no question that it needs to happen. And this, to go back a little bit to this, I'm afraid of getting sued. I don't really want to say anything to anybody. There's a couple really good papers kind of in the middle of this section that address this. First of all, if you have full disclosure, will you be sued more often? The answer to that is yes. The paper that addresses it, I'll look it up in here somewhere. It's from Kentucky. There was the Lexington, Kentucky VA hospital initiated a full disclosure policy where any medical, anything, whether there was a bad outcome or not, was told to the patients, flat out, across the board. They, in all of the VA system, became the most sued VA system within a very short amount of time. The patients were told a mistake was made, we are addressing the situation, we'll make sure that there's no cost to you as a result of this, and you have legal, there's a legal, if you want to sue, you can. That's what they were told in their disclosures. So people did. Okay, people absolutely went unsued, but they dropped to the bottom quarter of dollar amounts awarded. So they got sued more often. But as far as cost, medical legal cost to the system, it dropped. Why is that? Why did that happen? Yeah, they got sued more often. Of course they did. Why did the numbers go down? Less angry. Two great papers in the middle of this, and I'm sorry I don't have the numbers straight. I didn't write this, so it's not organized the way I think. But in the middle of this are two papers that look at scenarios. They go to patients and they say, okay, here's the deal. We have a couple scenarios for you. One is it's just a wrong dose of a medicine that was given to you. Another is the doctor gives you a medicine you're allergic to and made a mistake by not looking it up in your chart. And the third one is a lethal outcome occurs. Okay, a doctor makes a mistake and you die. So here are three scenarios. What are you going to do about this? What they found, and here's three scenarios, and in this situation, they tell you they screwed up. And in this situation, they say nothing. It turns out that if you don't disclose for a mild bad outcome, moderate bad outcome, or lethal bad outcome across the board, if you don't disclose, they are more likely to sue you, they are more likely to report you, and they're more likely never to come see you again. If they're dead, they can't come see you again, so it makes that pretty clear. That what they can do to you, they will if you don't tell them. They're much more likely to do that. And they did a great thing. They took two juries that had heard malpractice cases. Took two juries and they pulled them away. They said, okay, you 12 people sit there, you 12 people sit there. They presented both juries the exact same medical legal case. And what they did in jury A is they said, and the doctors admitted their mistakes. In jury B, they just presented the case and no admission of mistake was made. 3 times the dollar amount in the I didn't admit mistakes group than the I admitted mistakes group. And they did it because they were pissed that you tried to hide a mistake that you made. They were like, okay, yeah, mistakes happen. There needs to be some compensation for this. But these doctors really, they said what went wrong. The system, they addressed it up front. Let's award some money, but not as much as, oh, you tried to hide it. We're going to get you with money. Okay, and they do. They absolutely do. So that there is a lot of not just ethical and moral issues that say disclosure is important, even on the stuff that scares us, like medical legal concerns. Will you maybe sue more often? Maybe. But if it does even end up to some dollar award, it tends to be less, especially if it goes to a jury. So I think that's if that needs to be your impetus, I think that's a pretty compelling argument to disclose. What are your sort of experiences with disclosure? You want to tell any stories? Yeah.
So if you disclose it, you get sued more.
Mm-hmm. Yep.
So just
right? But if you do get sued, it's going to be a bigger, uglier, more dollar amount case. You should do the right thing, which is disclose. And I know it's uncomfortable, and what we're pushing for here is sort of a 2-level change in attitude. Because I know it is really hard to say, "You God, I screwed up." So we're trying to do 2 things. One is to change the idea that you, by disclosing a medical error, you are somehow a hideous human being. You should not be practicing medicine. That you are a bad person. That's not the case at all. And the second thing is that it does, in a system-wide way, help us address minimizing error in the future. We do this, the reason that the safety net thing at Harbor has been really interesting, because we're finding that recurrent mistakes getting made were easily remediable, like armband issues. Or our biggest problem, one of our big problems, is we have 50,000 Maria Hernandezes and Juan Lopezes. And we were finding that medical records were getting screwed up and tests were being done on the wrong Maria Hernandez. And we were finding that just checking armbands and double checking birth dates made a huge difference in our potential, in our error. But if we hadn't said, we did the wrong study on the wrong Maria Hernandez, no one would have looked into the issue. So part of this is to help as a system to decrease errors as well. Yeah.
The bit about reduced damages because the jury is not so upset if there's full disclosure.
Mm-hmm.
Does this translate into other jurisdictions? For example, in Australia, it's not a jury that determines damages, it's done entirely by the judge.
Actually, I don't know. I haven't seen any studies that deal with a magistrate equivalent who makes the decisions. I don't know. I'm not sure. You guys aware of any data? I don't know.
But if there's no psychological differences in the people doing suing, non-disclosure might be better in a jurisdiction that doesn't have juries.
Maybe. But then there's the ethical issue as well. Part of this is, too, I think we expect a lot of ourselves and of our peers that is unrealistic. It's not like you're dealing, medicine means that the human body will die. Something will go wrong. It is an inherently flawed system in which we put fingers in the dike along the way. It's a complex system where it's not an off-on switch, it's not a black-white issue. There are a lot of shades of gray. So mistakes absolutely can occur. There's just no question about it. And part of this vilifying of people or suing them to death is not the right approach to making it better for everybody, making the system better for everybody. And we're in a big switch of this. And part of it is to take the word error out and put in something like adverse event. Because an error implies that you made a true mistake versus sometimes bad things happen. You had a side effect of the drug that we know happens sometimes, and wow, you had the bad one. You anaphylaxed and you died. Okay, that's an adverse event. Did we have any culpability in that? Let's go back and look. Oops, I should have checked that penicillin allergy. I didn't. Or it just happened. But if we don't start to address this stuff, we won't ever make the system better. So, yeah.
Sometimes we have our triage nurses order things before you actually see the patient. So say they order x-rays and the fight is not appropriate. Do you go in and say, oh, we made an error, or you just kind of correct it on the form?
It's funny you should say that.
Order the right x-ray.
Yeah.
Take it off the bill.
Right.
Do you tell them, well, sorry, we irradiated your head when we meant to?
Oh, I got stories to just turn your hair grayer. This is, seriously, our system at Harbor that I was bitching about yesterday morning, excuse me, this is on tape, I was complaining about yesterday morning, that when they've hired this second set of docs to be out in triage to address our big deal, now we have talk about a setup for disaster. 2 days ago? No, 3 days ago, whenever that shift was. We got 2 patients, they got belly CTs twice. Because they got it ordered out at the medical screening. We didn't know it was ordered in medical screening. We ordered it in the back. Patient didn't tell us, despite our asking, that they'd had a CT scan. They got radiated twice, both of them. Crazy, crazy. Radiation risks you're going to hear about in this course. That's nuts. That's crazy. One guy was under 30. Yeah. You see progression of disease on scan. And you're right. So you have these systems. This, again, is a systems problem. Our system, to try to put fingers in the dike, is doing things like having tests ordered. We had D-dimers that are all over the place. BNPs I would never order. So it's crazy. It's absolutely insane. Crazy stuff. But that's a systems issue. And if the system gets somebody radiated twice, we talked to both of those patients. We sat them down and said, You got 2 studies. We're really sorry you got 2 studies. We don't know the long-term effects of that to your body. We know that the short-term effect is you're not getting charged for 2. You know, it is really a problem. It's really, you're absolutely right. Our trying to fix the system sometimes makes systems issues that are worse. So we actually apologized in both of those cases. Yeah.
I think his point was, I think we all agree that we should be honest and disclose errors to the patients, but it's not always black and white.
Exactly.
So if a nurse misorders an X-ray, does that fall into that category where we should disclose to the patient?
So you're saying like they get like a foot instead of an ankle, or a, yes, I do think so, because, and especially you shouldn't be charging for 2. If the system ordered it, and so part of the deal is you explain the situation. You got your, I'm sorry that I know you went to X-ray once. I need to send you back because the new film I really need is this. The first one that was ordered probably wasn't appropriate, and what we'll do is make sure you don't get charged for that, but let me get the right film.
Well, that's kind of clear cut, but there are going to be cases where it's grayer.
Mm-hmm.
So like even a nurse ordering an X-ray that you really didn't want, and it was already because you're busy, it was done, and do you tell the patient, well, I didn't really need to order this X-ray, but we're busy, the nurse ordered it.
Well, I think how you word that, I wouldn't word it that way. I would word it as our nurses are empowered to order the films they think are appropriate at triage. Now that I've seen you, I think something else is what's indicated, and probably you didn't need that film, so let me make sure you don't get charged. Or if it's something you would have wanted anyway. Say it again?
Would you put that in the category
No.
where you would disclose that to the patient?
Yes.
You would?
Yes. Isn't that that's part of the bedside manner issues? I mean, explaining to somebody why you're sticking them again in the back when they got stuck for blood draw out front, or sending them back for a film when they already got a film, you got to explain that. That's part of the bedside manner part of this as well. So anyway, one more thing, and then I think we're switching. Mel, are you next? Okay.
In California, if you have a single malpractice award that's over a certain dollar amount, you get investigated.
Mm-hmm.
Is there also a trip for that for a number of cases?
Oh, I don't know. That's a good question.
Instead of one case over 30,000,
Right.
if you have 10 cases under 30,000, does that trip an investigation?
Actually, I don't know that. You're right, though. There is a trigger that involves then the medical, which is kind of, I find that a little bit problematic because you have only so much control over what things get settled, and so I do have a little problem with that. And part of this is very imperfect. I mean, there is an interface with the medical legal system. There is an interface with ethics, and it's different in different countries. Every country is different as far as sort of the reporting issues and the disincentives, et cetera. But I just think the concept is really important, and I think is in the purest of systems, the most ivory tower of systems, is you talk to your patients, you let them know what's going on, and you certainly don't want to repeat a process and have a process continue that is harming people if there's a way you can fix it. So, and I work in the probably most dysfunctional hospital, except for maybe Mel's, on the planet, so I can speak to this with some experience.